Good afternoon, everyone, and you're welcome to this webinar this afternoon. We would like to thank those who have joined on time and would like to kindly request that we give 2 more minutes to those for other people to join. We'll be starting our webinar very soon. You're all welcome. So we are all on webinar mode, and you don't have access to your microphone, but during the presentations, if you have a question, please kindly type in the Q&A, and then we would address them during the question and answer session. Thank you.
Peter Kebila, if you are on the call and maybe you've joined with another username, you may let me know so that I can add you as we planned. Thank you.
Okay, I see that more and more colleagues are joining. We are going to start at 5 minutes after the hour. Thank you for joining. Okay. I think we are going to start with the webinar. Good morning, good afternoon, good evening, depending on where you're joining us from. So you are kindly welcome to this webinar entitled Championing a Critical Paradigm Shift within the African Health Research Ecosystem. And we are going to be together for the next 1.5 hours. I'll start by introducing our moderator. So our moderator for this afternoon is going to be Dr. Jackie Stewart, who is an Associate Director at the International Collaboration and Partnership Center for Health Policy. She's a co-director in the Institute for Inspiring Children's Future Doctoral Research Center, Health and Wellbeing Research Cluster Lead. She's also a lecturer in the Department of Social Works and Social Policy in the University of Strathclyde in Scotland, and an adjunct professor, associate professor in the Department of Family, Community and Emergency Care in the University of Cape Town. She is also one of the members of the expert committee that worked in collaboration with Africa CDC to develop the African-centered research prioritization framework that we'll be discussing this afternoon. Dr. Jackie, you're welcome. Over to you.
Thanks so much, Elvis. I'm really excited to be here and moderating this webinar together with Elvis. Yeah, so it's lovely to be doing this in partnership with Africa CDC in my role with the University of Cape Town, and more recently with the Center for health policy, as Elvis said, at the University of Strathclyde. So we also have some Global North people joining, which will be very useful indeed to hear also their comments and thoughts. So we're going to start with some opening remarks from Africa CDC, and this will be presented by Dr. Falla. So Dr. Falla is the acting director of the Center of Science and Innovation at Africa CDC, and he's the lead of the research pillar of the Incident Management Support Team, which is a multi-stakeholder coordinated response to mpox, as well as outbreaks that other outbreaks. And so that is jointly led by Africa CDC, Center for Disease Control, and WHO, World Health Organization. I'll hand over to you, Dr. Falla.
Thank you so much, Jackie. Thanks to Elvis for organizing the meeting and all of the committee members, and thanks to our 192 audience who have joined us. It is very crucial for us to, hope you can hear me. Can you hear me?
Yes, we can. Yes, we can.
Great. So why paradigm shift? Why do we need to look at the research ecosystem in Africa? Last week, I did a presentation to the West Africa Consortium of researchers from West Africa that came together after the 2014-2015 Ebola outbreak. And I was giving them the reason why we need to refocus, retool R&D. R&D is a step towards local manufacturing, which our DG always refer to as the second independence of Africa. And the statistics are very revealing. Africa accounts for 18% of the global population, 25% of the infectious disease spreading. But of all the clinical trials conducted, Africa only contributes 1.2%. In terms of total health product, Africa is contributing only 3%. Probably the way I want to put it in perspective is the recent example given by Jeffrey Sachs. Jeffrey Sachs said, Africa 1.4 billion, China 1.4 billion, India 1.4 billion. However, Africa imports 99% of all of its vaccines. In order of total revenue from manufacturing R&D, India comes after China and China comes after the US. So you see the contrast. But the argument I was making why we needed to invest in R&D so that we could support and empower local manufacturing were threefold. The first one is that Africa remains very vulnerable to emerging and re-emerging infectious diseases. A few days ago, a friend wrote me and said to me, I think I'm done with mpox. What is the treatment you can recommend? And I said to her, Sally, there is no treatment. And my mind raced back to 2014, 2015, when I was in the head of the Ebola outbreak, and we'll say the same thing, Sally, there is no treatment. That alone, there is no treatment. Vaccines that we have are inadequate. And so we are disadvantaged. The first and foremost issue that we need to invest is the fact that since we're not driving our R&D agenda, we are not prepared for any of the diseases that threaten our continent. That's the first argument that has to change. We have to change so we can prioritize our R&D to support local manufacturing. The second is the fact that even our burden of disease, common diseases, chronic diseases, all projections have shown diabetics, HIV, TB, malaria will continue to increase in the foreseeable future. There is increasing demand for drugs, alternative drugs, and diagnostics. Africa is wholly unprepared to be able to provide the medicine and the drugs for its population. The final argument is the argument of economics. So I presented to the group a very striking photo. Between 2018 and 2023, India pharmaceutical company grew from $19 billion to $50 billion in 2023. And then I showed the GDP of most of the African countries. What India made in 2023 is equal to the GDP of 8 to 10 of our countries in Africa. Africa has an emerging young population that are jobless. The entire pharmaceutical R&D to support pharmaceutical industry provides an ecosystem to create jobs across all of the services and systems. We need to change the paradigm. Things are just not the way they're supposed to be. In terms of threat, in terms of disease spreading, from an economic point of view, we need to shift. Only by shifting and investing R&D to produce local manufacturing will Africa see changes in the way we die whenever we have outbreaks, the way our people die every single day, and to improve our economies. So thank you very much again, Elvis, for the opportunity. As you go through the deliberation, let's think for the reason why we need to shift the paradigm, why it needs to be done very urgently. Thank you very much.
Thank you so much, Dr. Falla, for really contextualizing the global landscape that we're finding ourselves in. We are now going to move on to two presentations. So the first one will be by Dr. Elvis Temfak. Dr. Temfak is the head of the Division of Research and Development and Clinical Trials Coordination at the Center for Science and Innovation at Africa CDC. He is actually leading the coordinated approach for a paradigm shift within health research in Africa. And today, Dr. Temfak will be presenting on the health research prioritization framework for the African continental research agenda. Over to you, Elvis.
Thank you very much, Dr. Jackie. Can you confirm that you can see my screen in presentation mode?
Yes, we can.
Okay, thank you very much for giving me the floor. So the outline of the presentation is we're going to look at the overview of the burden of disease and the landscape of R&D, as Dr. Falla mentioned. And then we're going to look at the coordinated African health research agenda for R&D, and then a synopsis on the continental R&D coordination mechanism. As previously mentioned by Dr. Falla, the continent is home to about 1.4 billion, and we have about 20 to 25% of the global burden of disease. And this proportion of burden of disease led to about 243 billion income lost in 2015. And close to 60% was associated to communicable diseases, maternal and newborn and child health, and nutrition-related problems, as well as 1 out of 3 associated with non-communicable disease. Even though we have twice the burden of infectious diseases, we are undergoing an epidemiological transition where there is a soar in the burden of non-communicable diseases. Just an overview on the public health emergencies, as well as the ones associated with communicable diseases and those that have outbreak potential. In 2022 alone, Africa CDC reported 152 public health events, and this increased to 182 in 2023. And by 2024, we were already at 213 public health events, which showed a 41% increase in 2 years. And if you check on our website, you will see that so far, we have reported by the 18th of May, 64 new events, of which 129 active events, of which 64 are new. So if already in the middle of the second quarter of the year, we are at 125 events, where are we going to be in December? So if we have to have a look at the R&D landscape for high fatality diseases, I'll take a case of Ebola. When we look at the map that is on the left of this diagram, we see that Ebola is a disease that causes outbreaks in many countries across the continent, precisely in the western, central, and eastern part of Africa. And when we go down the history of Ebola, we see that even though this diagram doesn't really give justice to to the number of cases, we see that sometime in 2014, there was a major outbreak that led to close to 30,000 cases. And these outbreaks, we have had relatively smaller ones that have been occurring on the continent. And I think last year, we were at the 10th year after the massive Ebola outbreak in West Africa. So if we ask ourselves the question, this disease that has been causing numerous outbreaks on the continent almost on a yearly basis, that led to a massive outbreak in 2014, where are we with respect to preventive measures? Do we have an effective vaccine? I leave you to answer that question. Are we able to detect and diagnose Ebola in the areas of high probability of outbreak occurrence? Do we have point-of-care tests? Because we really need this point-of-care test, because in many instances, the outbreaks don't start in urban areas where we have access to complicated methods of diagnosis. Are there any effective therapies for treating suspected or confirmed cases? And since the late 70s, has there been any improvement in the case fatality? Because I'm sure if we go into the details of each and every one of these outbreaks, irrespective of their size, we had a minimum of 1 out of 2 cases becoming fatal. And we are still to understand what are the major environmental, behavioral, social, and other determinants of the reoccurrence within the same regions. Because if you look at this map, you see West Africa, Central Africa, and Eastern Africa are areas where there are high risk of having this outbreak. Then if we go to another case of where do our priorities lie within the global priorities. Last year, Africa CDC launched this very important document, which is talking about the new priority, the new pandemic, which is that of antimicrobial resistance. And in this document, one of the key things that came out was that we really need to voice out African priorities. And when you look at this diagram, you will see that on the WHO bacterial priority pathogen list of 2024, we have high priority pathogens. And when you look at the key to this map, to this diagram, you will see that African priorities, which are represented here in pink, are either medium priorities or they do not even appear on the priority list. Let's take a step further, using the case of Mpox. When you look at this, when you go to Africa CDC website and go through the reports of Mpox since 2022, I wanted to draw your attention that in May 2023, just a year after the out of Africa outbreak of Mpox that happened in more than 37 countries, by the time Mpox was being declared as no more a public health emergency of international concern, there was still many cases of transmission. There was still many transmission in 5 member states on the continent. Then 1 year down the line, this transmission was still sustained in 6 countries. And by the time we were in August 2024, sustained transmission was ongoing in about 12 member states. And this led Africa CDC to declare Mpox as a public health emergency of continental security, followed immediately the next day by WHO's declaration of it being a public health emergency of international concern. And by December 2024, we had sustained transmission in 20 member states. And as we speak, currently there is sustained transmission and increased number of cases in 25 member states. And I think we are all aware of the increase of cases in Sierra Leone. With this, it calls for a need for an integrated and coordinated research as response to the public health problems in Africa. This coordinated approach is deeply incorporated in the strategic plan of Africa CDC. Africa CDC, whose mission is to strengthen Africa public health institutions and systems capacities and capabilities and partnerships to timely prevent, detect, and respond effectively to public health threats and outbreaks based on evidence-based policies, programs, and intervention, has really identified research as a cross-cutting enabler of the priority areas where Africa CDC supports member states in building their capacity. And in this specific area where we are thinking of research as being an enabler, there is need for a strengthened public health research and innovation to improve public health decision-making and practice. And for us to be able to do this, we have three main objectives within the Center for Science and Innovation at Africa CDC. One of them is to develop a comprehensive African health research agenda. And this is going to be our focus of discussion today. Another one is, which we are going to touch very slightly, is to improve and coordinate the health research ecosystem and make sure that the outputs of research are going to strengthen policy guidance and innovation. And as Dr. Fala earlier mentioned, this is going to create the foundation to support the platform for harmonized harmonized African health manufacturing. And for us to be able to develop a comprehensive African health research agenda, there was need for us to develop a framework that is going to guide this process. And if you look at the framework, we identified key principles. One of them is ethics, and that's going to be the discussion in the next session. But I want to draw your attention to the fact that we cannot do this without being inclusive. And the inclusivity in this case is for us to ensure that within our member states, there is a multi-stakeholder consensual approach which will permit an in-depth situational analysis using local data to understand where we are with respect to research in each of our member states. Now, so for the process of prioritization, why are we even doing research prioritization? First of all, we have to acknowledge the fact that resources for research are limited and or are scarce, and with the current situation where ODA is really shrinking, there is need for us to be able to choose where we invest the limited resources that we have. Secondly, we earlier saw that in many instances, African priorities do not feature in global priorities. Moreover, we really want to identify health problems that if we address them using research, they have the potential of impacting positively the lives of the people who are affected. Who are the people to participate in this process? Remember, I mentioned inclusivity. It's a multi-stakeholder approach where each of these stakeholders are involved from inception, especially the people who are suffering from the major problems that we want to solve. And this prioritization framework is designed in a way that it can be used at subnational or at institutional level, at national level, regional or at continental level to be able to identify the priorities. And how are we going to do that? It's going to be through a systematically guided methodic approach, which is going to facilitate the process of us aggregating either the subnational priorities to be able to see a clearer picture of the national priorities, or aggregating the national priorities to identify regional ones, and aggregation of regional priorities to be able to come up with a continental agenda. And at what frequency do we want to do this? These timelines are going to be defined by us, all the stakeholders involved in this process. And so, given that we said it's going to be a multi-stakeholder, consensual, situational analysis of the realities in each and every member state, we drafted some questions along specific criteria to guide the discussions to facilitate identifying where the priorities are going to be. And during this multi-stakeholder in-country situational analysis, we bring the stakeholders to ask themselves the questions: what are the diseases that are prevalent within the different thematic areas in the main country in question? So this goes through a shortlisting process to consider their context. We should be mindful of the fact that one of the key characteristics of Africa is the diversity in terms of geography, population, fauna, flora, and what have we. So the epidemiology of diseases is not uniform in all the countries, and we need to consider this during the prioritization process. And for the criteria that we have earlier mentioned, we need to identify what are the different levels that we think really describes the reality of the context. So it has to do with the current situation. And in this process, given that we need to make choices, what are the trade-offs that we are making? in deciding which level is better suited for each criterion. This can only be achieved by consensus through the different stakeholders who will be involved in the process. And what extra information do we need? And that is one of the reasons why we are really encouraging our member states to rely on their locally available data, epidemiology data, surveillance data, survey data, and all of that. And how would the stakeholders ensure that with the same information, another group of stakeholders will not come out with a different weighting of the different criteria? That is one of the reasons why we think the process has to be systematic, guided, and objective. So with the 5 criteria that I mentioned earlier, we developed a simple equation that is going to permit us to rank the different health problems, considering the level of prevention, the level of detection in the member state, the morbidity associated with the disease, the availability and effectiveness of the different types of treatment, as well as the mortality associated to this. Without going into the details of this, each and every one of these criteria with their levels have defined defined parameters that were developed through a discrete choice experiment in which we generated about 14,000 individual data points. And with this, the process is just to have a linear equation that considers each level of each criterion to generate a score. But considering that these scores have no meaning as a value, we had to transform that using a conditional logic model to generate probabilities of a specific disease condition being classified as a probability, as a high probability, moderate, or low probability. And with all of this data that we generated, we developed an online tool that is going to help member states in the process, whereby all the different shortlisted diseases in the thematic areas, either at the national level or the subnational level, would be shortlisted, as I mentioned earlier. And then through consensus, different levels of the criteria would be chosen and then entered into the tool. And upon final submission, it is going to calculate the probability of each disease being a low, medium, or high priority and classify them accordingly. I just want to draw your attention to the fact that this is dummy data that we generated just for the purpose of this webinar. And this does not represent what happens in the member states whose name appears here. So for this process, we are using this framework to support our member states to actually carry out this prioritization process as earlier described. Currently, we decided to start with West Africa, and as we speak, we have already completed the process in 11 out of 15 countries in West Africa. And currently, as we are in this webinar, the process is ongoing in Senegal and Guinea-Conakry, and we intend to complete West Africa by the end of June this year. And by December, we should have done 25 more countries to attain 40. And by the end of the first quarter next year, we should have carried out the exercise in all the 55 member states. And as you see, the methodology is developed such that using the same approach, we can aggregate the priorities within the member state in the region to generate regional priorities, such that the aggregation of these regional priorities would come out with a continental research agenda. However, even though the process seems to be very simple, when we develop this agenda, there is need for a continental coordination and governance mechanism to ensure that we use an objective approach on how to address these different priorities. And for this, we developed a continental R&D and governance and coordination framework. And this framework has a hierarchy such that we start at the regional level, where there's going to be an advisory committee to guide on how we address the different priorities that come from the region. But I would also like to draw your attention to the fact that this approach goes up to the highest level of leadership, where we are going to have an honorable ambassador for R&D in Africa chosen by heads of state and will be one of the heads of states. Considering the time that we still have, in order to have more information about this continental governance and coordination framework, we invite you to consult this paper that we published a few weeks ago, which really spells out what this continental governance mechanism is all about. When we have this governance mechanism in place, there is just no way we can do objective research without involving ethics. So there's also a paper that calls for an African-centered health research ethics that you're going to hear more on the process of development by the next speaker after this. So as a take-home message, for us to be able to attain Agenda 2063, there is a need for a paradigm shift in the African health research ecosystem. And this requires that R&D should be patient-centered, priority-based, and impact-focused, leveraging local capacity. That is one of the reasons why we are counting on our different member states stakeholders for the success of this process. There is need to involve multiple stakeholders in all the member states to ensure that we can leverage and optimize our available resources and avoid duplication of efforts. Partnership that is action-oriented, and the center of which the interest of the people suffering from the health problem should be the main interest of all the people who want to get involved in this process that we are currently advocating for. On this, I would like to thank you for your attention, and back to you, Jackie.
Thanks very much, Elvis, for really giving us a in-depth look at the health prioritization framework. I know it was really hard to summarize that into such a short presentation, but yeah, you really did a fantastic job. And just to say, as someone who was part of the health prioritization process in the Gambia recently, it was really wonderful to see numerous stakeholders sitting around one table, or numerous tables depending which theme they were talking to. But we had research institutes, we had clinicians, we had service users, third sector organizations, and it was one of the first time for me in my 30 years of practice, public health practice, actually hearing conversations where a clinician will say, well, this has been my experience, but I don't think we have data. And then we hear a research institute say, no, there's loads of data on this. Let's go to this database and I'll show you. So that kind of collaborative approach, yeah, really seemed to build capacity and relationships, which was wonderful to see in a very consensual process. So thanks very much, Elvis, for going through that. We're now going to move on to our second presentation that will be presented by Dr. Bugahare. So he's a senior lecturer of philosophy and bioethics at Makerere University. He is a founding member of Uganda's National Bioethics Committee, the Africa Bioethics Working Group, and he also serves on 2 additional research ethics committees. He is speaking today as a member of Africa CDC's Ethics Working Group to support the developments of the framework. And so I will hand over to Dr. Bugahare to give his presentation on an African-centered ethics framework.
Thank you for the introduction, and thank you, Elvis, for organizing this webinar. I'll share my slides, a few talking points that will guide me through this talk. Can you see my screen?
Yes, we can.
All right.
Are you able to just put it into slide mode?
Yeah, of course. Okay.
Great, thanks.
Yeah, so as I've been introduced by Jackie Stewart, and my role today is to speak about the framework we have developed that is supposed to guide research during epidemic and emergencies, public health emergencies as they occur so frequently in Africa. So basically, this framework, which is called the African-Centered Ethics Framework for Research during epidemics and public health emergencies, was conceived, the idea was conceived about 2 years ago, I think from around 2023. And then we've been working on this until I think this year when it was launched. And I want to speak about its rationale, its values, and its principles. So basically, my starting point will be an appreciation of the theme of this talk. This theme called championing a critical paradigm shift within the African health research ecosystem, according to me, is a call for a revolutionary turn in the ways we perceive and act on health research in Africa. And that being the case, one of those turns within the field of ethics is coming up with this particular framework that we are talking about. But the most important thing is to, first of all, get to appreciate the rationale of this framework. Why did we need to develop this framework? Especially given that we know that internationally, there are a number of ethics principles, guidelines, right from the Declaration of Helsinki and all other guidelines. Why would we need an African-centered ethics framework for research during epidemics and public health emergencies? One of the concerns when you look at the literature on African bioethics or bioethics in Africa, there is a huge concern that the existing ethics principles that guide health research are largely Eurocentric in nature. And even though that in itself is not a problem, there is nothing inherently wrong with being Euro-American, but the main concern is that sometimes these ethics principles and theories, they fail to address the specific or the contextually sensitive ethical issues that arise. And they also sometimes fail to be responsive to the cultural nuances of Africa. That's one of the reasons we thought that it may be necessary to come up with an African-tailored ethics framework. Then there is some other big worry about the existing ethics and its history. One of them is shaped by the worrisome history of the North-South interactions as it is all known. First of all, its imperialistic and exploitative nature, and then the need to stop or to make sure that we mitigate its replication through health research. So, and looking at some of the recent developments, as I mentioned, this process of developing this framework came at the end of COVID-19 pandemic, at least its peak, the end of the peak, which was around 2022. And you all remember some of the remarks that we had with regard to COVID-19 research. One of the proposals was that the riskiest COVID-19 clinical trials should go to Africa. And then, of course, there was some other ethical issues that arose in research and responses following the 2014 to 2016 Ebola outbreak in West Africa. And what we have observed over the time, as Elvis has mentioned in his presentations, rather in his presentation area, these outbreaks have taught us one thing, that when these outbreaks come, they provide a fertile ground, they increase the risk of unethical research on the continent. Apart from those worries, of course, there was a need to standardize applicable ethics norms and standards within the African continent in such a manner that if any investigator outside the continent comes and wants to conduct research on the continent, it will be difficult for them to target a certain country just because they think that they have weaker research ethics regulatory systems, and therefore they can go there and conduct an ethical research. So the essence of standardization is that it doesn't matter where researchers outside Africa go, they will find exactly the same ethical requirements. Also, there has been a need, and this has been a long overdue need, to make sure that we improve the responsiveness of health research. This responsiveness should be to Africa's health needs and priorities. And I think Aries has talked about the issue of prioritization. And of course, there is a need to be responsive to African cultures and values to make sure that research takes place in a manner that is consistent and responsive to the various social, cultural, ethical, considerations that are so different in different African communities. And of course, this responsive is supposed to assure adequate protection for participants and communities. Another goal as to why we need to engage in this revolutionary turn within research guided by ethics is that there is a need to improve post-study access in Africa as a way to make sure that we realize equity and the actual utility of research. As I mentioned in one of my papers recently, the ultimate goal of conducting health research is to make sure that we improve people's health opportunities. And it wouldn't make sense if we think about ethics in a narrow sense, as if it consists in merely sanctifying the process of research, and then we don't discuss issues to do with post-study access. If we fail to address those issues, then it will mean that we are not realizing the ultimate goal of that kind of research that we are conducting. Of course, as Dr. Farah has indicated, health priority setting, especially in the field of research, needs to be informed by ethics. So there is a need to mainstream ethics consideration within health research priority setting, because priority setting in research as well as in care implies, or it reflects, ethical values that we hold. So any decision with regard to priority setting can be assessed from the point of view of the ethical values it informs. So this means, before I go to the actual principles that are within the framework, it means that unless we revolutionize, unless we transform the way we think and act in relation to research ethics, we are not likely to achieve the goals that we want to achieve through health research on the continent. We need to understand the various drivers, the various interests that drive research on the continent, whether it is that kind of research that is domestically funded or it is international collaborative research. We need to appreciate the circumstances in which it is taking place, and that way we will be able to develop the kind of holistic thinking about research ethics that will guide us to through the kind of revolution that we are talking about. So looking at the framework that we developed and having surveyed a number of research output in the field of bioethics in Africa, and of course, African philosophy, we identified a number of values and principles and the values, rather the duties they give rise to for the various actors, for the various stakeholders. Key among these values that we included are solidarity, friendliness, social justice, and then the principles they give rise to. With regard to the principles, one of them is collaboration. And this is not just collaboration, but we should describe it as ethical collaboration, in which the various collaborators are treated as equal, and it is not characterized by the usual power asymmetries that give one party an advantage to dictate about how things should go within that collaboration. And by stakeholders to collaborate with, I mean the collaborations between researchers and the research participants, the researchers and the communities, the researchers and their funders, then institutional collaborations, and all those. But the most important thing is that these collaborations need to be ethical. And I think there is a lot of work going on about how to make sure that collaborations, especially those between the global north and the global south, are ethical and equitable. Then the next principle is that of utility or responsiveness. Now, this is critical because, as I mentioned, the ultimate goal of research is that at the end of the day, we should be able to improve and avail better health opportunities for the population among whom research is conducted. And that's what makes it very critical to make sure that as we conduct research or we negotiate the terms of research in the collaborations, one of the things to emphasize is how or to what extent does this research address the needs and priorities of the people among whom it is going to be conducted. Of course, unless it is of relevance, their health needs, it's difficult that they are going to optimize the kind of utility they can obtain from that. And after confirming that, the next thing would be looking at the various arrangements that have been put in place to ensure that if the trial products or the study products being studied have been proved to be safe and efficacious, how will they be accessible to the people among whom research is conducted? Without doing all those things, it's difficult to realize the utility of research. And then responsible science. I think this is a common standard, but responsible science in this case, we mean that the science that should be conducted in the kind of research in Africa, we need to make sure that it meets both the scientific and the ethical integrity of research as we all know it. Of course, then another principle is that of empowerment. For a long time, whenever we talk about international collaborative research and all those things, we talk about issues to do with empowerment. Empowerment in terms of the scientific knowledge, empowerment in terms of the ability to engage to increase our bargaining power in the kinds of collaborations we undertake. And the essence of thinking about this from the point of view of Africa or African interest is to make sure that it becomes a reality. If we are going to do all those things that have been talked about by Elvis and Farah in his opening remarks, making sure that we go beyond just basic research and then we go into R&D, we have no choice but to think about the strategies through which we can build capacity for Africa. All these principles give rise to some duties to a number of stakeholders. And these duties, when you look at the actual framework, which I think should be available online, they are categorized under 3. One of them is the duties that are supposed to be fulfilled during the pre-research period when we are planning research and doing all those things. There are specific duties that are supposed to be met. And then during research, and then post-research. Some of these have been, implied by what I've said. For example, when you talk about pre-research obligations, we know that engaging the communities through, rather in which research is going to be conducted, is one of those pre-research activities. Then during research, we're talking about the protections given to the study participants, making sure that research conducted in Africa, especially if it is foreign funded and with foreign collaborators, it takes place in a manner that is respective of the values, of the taboos and norms and all those that pertain to the people within that community. And then post-research here, we'll be talking about post-study access. And I need to emphasize the idea of post-study access. In most cases within, the Eurocentric or Euro-American-centric research, there is a lot of attempts to downplay the importance of discussing issues to do with post-study access issues. And of course, several reasons are given. But from a point of view as Africans, we say that if there are no guarantees as to how the African population is going to benefit from the study being conducted among them, including the time frame, then it's not worth undertaking. So these obligations, of course, or duties are supposed to be fulfilled by a number of stakeholders, including the researchers themselves, the participants, the communities, the ethics committees, the funders and partners, and of course, the very many policymakers. So going forward, as we continue to work on this kind of work, of framework and other steps that are needed, we are thinking about developing a continental research ethics governance framework. And some of the questions we need to answer as we go along and on which we may get feedback from you is how it should be designed, including its mandate, its composition, its modus operandi, and international coordination. Of course, we are beginning from scratch when it comes to ethics regulation at the continental level, but this is necessary, especially if we are to make sure that we end up with standardized ethics demands or ethics standards for conducting this kind of research. So, as it was mentioned, I'm making this presentation on behalf of the team that developed the framework, and here are they. I won't mention them one by one, but of course, one of them is obvious. You can identify him. Probably I should say that I'm the one who is third from right. So basically, that's what I have to say to give to you at this moment. So I'll wait for the feedback from the participants. I'll stop sharing now. Thank you.
Thank you so much, Dr. Bugarhare. That was incredibly interesting. And it was interesting listening to you talk and seeing the natural intersection between these two frameworks that I think Elvis has before referred to as like the finger and the nail, that the two are going to be very much interlinked. But to be able to look at funders and collaborators and where that funding often comes from in terms of the research that's run within the Global South often means then, as you say, that the priorities and the research that's done can often be skewed and not necessarily addressing the need of that particular member state. Whereas by using this framework, each member state is able to highlight what the health research priorities are for that country, and then open the doors saying researchers and funders are welcome within this framework, within this lens. These are our priorities. Anyone wanting to collaborate with us would need to be addressing some of these core issues. So yeah, thank you for that very, very interesting and critical call to action for a real shift in the, a real paradigm shift in the way health research is conducted. And as you say, all the way through to the end of the process, when we're looking not only at dissemination of findings, but what happens after, that research can't in and of itself be the end to that cycle. How does that actually tangibly benefit the communities and the country itself? So thank you very much. That was really, really very interesting. I'm now going to hand back to Elvis to introduce our panel. And I would encourage everybody, please, to, if you have questions as the panelists are speaking, please just pop a question into the webinar chat or the Q&A chat, and let us know who you would, if you're directing a question at a particular panel member. And of course, you may have questions specifically for Dr. Tempak or for Dr. Bugrahare, and that's also absolutely fine. So hopefully we have enough time to do justice to some of our questions. So Elvis, handing back to you.
Thank you very much, Jackie. Thank you very much, John, for the presentation. So I'm going to introduce our panel members. And one of the key expectations that we have from them is for them to tell us with what they've heard so far about this paradigm shift. How can academic institutions or the alliances of the different academic institutions support this R&D process from start to finish? As we mentioned, that the main objective of the R&D is to be able to produce products locally to address our priority health problems. So among the panelists, I'm going to start with Professor Tracy Naledi, who is an associate professor of public health medicine and a deputy dean, social accountability and health systems at the Faculty of Health Sciences, University of Cape Town. Tracy has held technical and managerial positions in government and NGO sectors in South Africa and Botswana. Her work includes the translation of research into policy and practice, addressing health inequities and strengthening systems for health. Tracy is the founding chairperson of Tekano, Atlantic Fellows for Health Equity in South Africa, chairperson of SHOCO and the Children's Institute, a board member of the Global Brain Health Institute and the South African Medical Research Council. Tracy is a Discovery Foundation Fellow and the Desmond and Leah Tutu Legacy Foundation Fellow. Over to you, Professor Naledi. Thank you for being with us this afternoon.
Great appreciation. Thank you very much for inviting me, and it's so privileged to have this opportunity and for offering our conversation. And I hope my reflections will build on the previous speakers. There we go. So I guess in setting the scene, I won't go into a lot of details because previous speakers have spoken about this, around just how much biomedical research costs, around the inefficiency really of how we take medical research and take it into clinical practice. And as Jackie was saying earlier, research cannot be an end in itself. And also understanding that there's actually a lot of research that gets done that does not get translated into practice itself. And that's just generally globally, but also getting into the African nuance around the disproportionate burden of disease that we have and the limited outputs of research that we have. And within the context of research, also understanding that there is actually quite a bit of mismatch in terms of the evolving needs of policymakers and practitioners and how we are able to actually produce the knowledge that is required to policymakers and practitioners to guide their practices and policy. And also to understand that actually research is not values neutral. And I think, as John was saying earlier, you know, when we're talking about how we find ourselves here, that there are political ideologies, there are budget constraints, and there's vested interest, and I think we need to bear that in mind. And I think Elvis alluded to this, is that we also need to recognize that when we're talking about health research, we need to understand what is the mission that makes us healthy as human beings. That in terms of kind of healthcare and those kind of biomedical issues, it's really only 20% of what they make us have. You know, there's behavioral issues, there's environmental issues, and those socioeconomic issues as well. So when we think about research, we need to think about it in a holistic way. And I think another piece that we don't really speak about is around implementation. How do we actually translate the things that we have found within clinical disciplines, population sciences, etc. How do we ensure that we translate that into actual policy and practice? And I think academic institutions have a powerful role in this interdisciplinary research and ensuring that particularly we are not leaving behind the translational piece, so that we can really maximize the value of the research that we do. And also building on some of the things that John was saying, how do we decolonize research practice in particular? I mean, the earlier presentations have really been talking about how do we as Africa reclaim Africa's agency in priority setting and kind of decide for ourselves what matters to us. And I think, thank you, Elvis, for sharing what you've shared, just to show very much in a graphic way where we are in the priority list. But the question that I have is, who are these priorities for? Are these priorities for academics or for communities, or for both? Are communities just people that are participants in our research, or are they co-creators of this research? And if they are co-creators of this research endeavors, we have to recognize that there are these dynamics of power, of language, in the manner in which we actually engage with communities. And in fact, the manner in which we speak as academics, as all these clever people, may silence communities. And really, if we are interested in co-creation with communities, we need to start listening in the ways in which people actually speak, not in the ways in which we publish, and acknowledging these power differentials. And when we decolonize these practices, really prioritizing those local languages, the valuing the indigenous knowledge systems, and ensuring that our communities are not just participants, but they're actually co-owners and co-producers of this research. And I'm really inspired in particular around the experience of Africa, particularly when it comes to HIV. When HIV started, many people didn't think that Africa could do it. They thought Africa, research in Africa, providing HIV in Africa would be so complex, African communities wouldn't be able to understand, blah, blah, blah. But actually, we've proven everybody wrong, where we've been able to get actually communities, people living with HIV at the forefront of research development, at the forefront of actually translation into policy and practice, at the forefront of advocacy. So for me, I'm really inspired. I'm not talking about high-future things here. I'm talking about things that we actually have experience of doing as Africans. And so as academic institutions, what is our role in capacity development? And so there's one, of course, this is around how do we develop this scientific workforce if we are going to be reclaiming this Africa's agency. We need people to be able to do this. And currently, our situation is not great. In South Africa, only about 0.2% of adults have a doctorate degree, compared to Australia, 1.7%, Germany, etc. And when we look at exactly where we're going in terms of producing the PhD and doctoral graduate population, we are not doing so great. But understanding that there's an opportunity cost in that, because what the evidence shows us is that there's a positive correlation between countries' GDP per capita and the proportion of the population that hold PhDs. And when we have a higher GDP per capita, we are able to invest into higher education, research, etc. And we've got this chicken and egg situation where in Africa, we've got low GDP. We are not able to invest into kind of generating a scientific workforce. So how exactly are we going to collaborate with our policy makers, with decision makers that can make prioritize understanding that in Africa, we've got many challenges, but if we are going to be a successful nation and a successful continent, how do we prioritize investment into research? And academic institutions can be these powerful knowledge brokers where, in the manner in which we actually translate the evidence that we find with systematic reviews, meta-analysis, etc., how to actually facilitating the communication between researchers and policymakers, and also researchers and communities as well. And there have been, as I said, some really great examples of how think tanks can do that, research organizations, and academic academic policies, partnerships, etc. But at the end of the day, it requires sustained engagements with individuals, professionals, communities, and organizations, and making sure, I once had a powerful comment to say, you can invite people around the table. Sometimes we do that with communities where we are a panel of academics and we'll say we have a community representative. Or we can actually go to the table of the community and actually speak to them in their language, in their context, and hearing them as well. So I think when we do talk about engagement, we do need to talk about what does it look like, and are we actually placating people and saying we are engaging just because it's a box to tick, or are we actually ensuring that we are co-producers of this knowledge and we are truly getting people to be part and parcel of the journey with us. And so in conclusion, I think my offerings that really, as African academic institutions, we are not just supporting actors, and I believe that we are actually the protagonist in the elaboration and implementation of Africa health research. We have multiple roles that span across research, training, translation, and I've added the piece around transformation, because how do we actually decolonize the discipline? How do we ensure that we are doing things differently to our counterparts in the global north? How are we ensuring that this is relevant and appropriate for Africa? And I think ignoring the contributions that African academic institutions have to make, what Africa has to make, I think it's really would forfeit Africa's future and health sovereignty. And I will just end it there for now. Thank you very much, Albert.
Thank you very much, Prof. Melody, for that very elaborate presentation. So with that transition, I'm going to introduce the next speaker, who is Professor Emiola Oluwabunmi Olapade Olaopa, who is the president of the Association of Medical Schools in Africa, a registered trustee of the World Federation of Medical Education. He's an advisor on health professionals and health system development to several African countries, international scientific and professional organizations, WHO, and the government of the United States and Finland. He is a former member of the Council of National Open Universities of Nigeria and the West Africa College of Surgery. Currently, he is a professor and head of the Department of Surgery, University of Ibadan, and an honorary consultant urologist to the University College Hospital in Ibadan. Mr. Olapade Olaopa's academic and professional career spans surgery, urology, molecular biology, medical education, biomedical research, and health system development. He is the 11th provost of the College of Medicine, University of Ibadan, and during his tenure, the college was ranked highest in sub-Saharan Africa by the Times Higher Education World University Ranking for Medical Schools, 2020-2021. He's also the Vice Chancellor, Thomas Basi Biomedical Foundation in Nigeria. Professor Olapade Olaopa has a patent and over 150 publications and 200 national and international invited presentations and abstracts. He's a fellow of the Nigerian Academic Science, Medicine, and Medical Specialties. Over to you, Prof. And thank you for being with us this afternoon.
Thank you very much, Elvis. Let me first of all thank the Africa CDC for inviting me to join this very great panel. I've listened to the talks and I've been really educated myself. I must in particular thank Tracy, who's made my own job easier because we're batting from the same side, and I'll simply continue from where she has left off. So I think we should consider the two presentations as the same. I'd like to share my slides.
Yes, I think you can go on and share. Thank you.
Thank you. Right. So without further ado, I'll just go straight ahead. Just greetings from Ibadan, which is the home of the AMSA Secretariat. It looks sleepy, but it has been the home of medical education in Nigeria and West Africa since 1948. Following on what Tracy has said, the way I see it, considering the topic at hand, a critical paradigm shift within the African health research ecosystem, I thought we should find out what the problem really is. And as Tracy has said, the real issue is that most African biomedical research institutions are not in the Africa research ecosystem. The ideas are brought from international institutions, which is not surprising because 90% of biomedical research funding comes from outside of Africa. So they don't need to derive it from our health problems, or indeed direct it at resolving those health problems. To the extent that some information is required of us or from us, then they involve us in the research. But in terms of generating the ideas, the methodology, and more importantly, owning the intellectual property that comes therefrom, African research institutions are not there. But I think worst of all is that most of the research output from African research institutions are not used by the governments in their national health policies. In fact, it's only of recent, and I mean of recent, that health training institutions, medical schools, and other health professionals, institutions were actually invited by the health ministry to contribute to policy making. That doesn't happen in many countries. Certainly in mine, it didn't happen until last year. So we're not there. To make matters worse, because we are not really there, we're poorly funded, because the chronic funding comes from the fact that nobody really thinks that what we're going to produce as research institutions are of any value as such. And most unfortunate is that our curricular and training methods are therefore not directed at generating graduates that are fit for purpose or fit of purpose for our own environment. This graduates employment mismatch then results in the inevitable poor retention and is a major contribution to the migration, because the graduates are more comfortable in Oxford than in Ibadan, or indeed in Makerere. It's often forgotten that there are fundamentals of a functional educational system. Education doesn't just occur in vacuum. If you want to produce a graduate of a certain sort, there is a way you go about it. And just briefly, if we look at the input, you really must have a good input. And as I shall show later, if you do not have appropriate primary and secondary school education, then your tertiary education is shot from the beginning. In the tertiary education, research comes in, because you must, as an output, produce new knowledge. That is when you then have the outcome of improved retention and sustainable economic social development and improved human development context. So once you've gotten your input and processes wrong, then your output and outcome can only be wrong as well. These are very new figures I just got literally today, that shows what is happening as regards funding of biomedical in Africa generally in terms of philanthropy. If you look at this slide from the OECD, African foundations contributed between the year 2016 to 2019 under 200 million, whilst foreign foundations provided 6.4 billion. Now, why would we expect any other result from what we have? He who pays the piper must dictate the tune. What is worse, even within Africa, when you look at it, in Nigeria and South Africa, when you compare them, the two largest economies, you see the disparate funding that occurs. Nigeria just had 12 domestic philanthropic organizations giving 90 million roughly in 5 years, 2013 to 2018. Whereas in South Africa, where obviously things are a little bit better organized, there was funding from 31 organizations giving 554 million, which means that it's an orientation of these foundations that is going to lead to the increased funding that we so much require to make any other thing, any other strategy we talk about effective and implementable. And as I mentioned before, you have to consider what happens across board. So if you compare Nigeria and Indonesia, two countries with similar colonial history and similar populations, you see that in the year 2014, 2015, Indonesia was doing much better than Nigeria. But if you compare those indices with 2017, 2018, you see that Nigeria's funding of the health and primary education had dropped significantly. Similarly, higher education. And of course, not surprisingly, the innovation that came therefrom and the overall contribution of education to global competitiveness from Nigeria when compared to Indonesia, the gap widened. So really is a question of dealing with all the processes, the multiple stakeholders, and funding all the appropriate areas so you can then have that paradigm shift. And which stakeholders are we talking about? Who we must talk to ensure that all what we're talking about is funded, because without funding, there's nothing you can do. Well, these are the alumni, the host communities. Tracy spoke about them being co-owners, very important. Let them put some money in. High network individuals, but most importantly are the industry and the foundations. The industry, because our graduates are meant to serve that industry. Once we do not have the industry involved in funding the biomedical research institutions, then you will not get them to be interested in you producing the kind of graduates they want, because they must have a return on their investments. And of course, the foundations. But is it really that there is no money available? Well, if you look at the figures put out by the Nigerian public private sector space, you can see how much money 10 of the most valuable companies earned in Nigeria, their output. 6.5 trillion was Airtel. Dangote was 4.6 trillion. And if you look down the line, these guys are making the money. It is we who are not going to them to get them interested in funding biomedical research. It never ceases to amaze me when I see them build some healthcare institution that within 5 years would not be sustained because it is not built on a sustainable platform. Biomedical research is the platform on which biomedical education, health professionals education, and healthcare must be founded, and it is locality specific. You can't repeat what is done in Oxford in Makerere. So we must have a situation where the research institutions and the local industry and foundations shake hands, at least under the table, if not on the table, so that there is an improvement in the quality of primary and secondary education, and there is increased capacity of and access to biomedical research institutions, so that we can reorient our curricula to serve the local needs, develop the necessary research projects, research ideas that industry will benefit from, and then encourage them to improve our research capacity and infrastructure. Continuing to do this, we now need to revive the Afrocentric orientation of biomedical research institutions. We must stop this idea of if you do not have an NIH grant, you are not a true professor. If you do not have some foreign stamp, you are not valued. We must go back and do what the objective of the main objective of the founders of biomedical education in Africa was, which was to have us delve into the local problems, research problems we have in Africa, and bring out innovative ways of resolving them our way, and if necessary, adopt our local culture and laws. Anytime I see people talking about arts in medicine in the United States, I laugh. All African countries, that is what was in our culture. We would always have some stories to tell you about health and all that. And we must strengthen the culture-based collaborations within HPTIs, because there's also a lot of silo attitude because of the fact that everybody's trying to protect his own funding source. Once we open that up and we engage all stakeholders, we would be able to move things forward. And of course, this would then lead, as Tracy was suggesting, to the development of the use of our local languages to be used for a teaching medium, without which you cannot engage the community. We've gone some way in doing that. We've produced quite a few pamphlets in local languages, which has helped us a lot. But recently, a few years ago, we produced a book, an introduction to anatomy in local language, our local language of Yoruba. And this has helped our students, has helped the secondary schools, and helped the patients. So this is possible, but you need funding. Of course, we did work with some WHO. So in conclusion, what does it all add up to? If we want a paradigm shift in Africa's health research ecosystem, there are unique challenges that we must identify because these demand unique solutions. And the overall goal must be an intent to develop local research capacity, but that this local research capacity must be included in the policy formation by the use of the locally generated research information by all the stakeholders, particularly the government, and local funding is the key. Of course, it's not just education and health that must be transformed in terms of sectors. All sectors must be transformed. And there must be a reorientation of all stakeholders, particularly our governments, who would rather look outside all the time rather than inwards. And with that, we'll be able to transform our biomedical training strategies to produce fit for purpose and those employable graduates, which is the mandatory endpoint outcome of this paradigm shift. I thank you very much.
Thank you very much, Professor Olawumi. And let me just go ahead to introduce Professor Margaret Kaseje, who is a distinguished public health specialist based in Kenya with over 3 decades of dedicated service to advancing health and development initiatives across Africa. Currently, she's serving as the president of the Association of Schools of Public Health in Africa. She leverages her extensive knowledge in health systems and policy to address critical health challenges on the continent. Her research interests focus on the vulnerabilities of populations amid evolving health priorities, emphasizing the importance of locally relevant health research. Professor Margaret Kaseje's collaborative work with various international organizations has influenced health policy and practice throughout sub-Saharan Africa. She is recognized as a leading authority in promoting community-led strategies and integrating ethical research practices into public health frameworks. Thank you very much, Prof. Kaseje, for being with us. The floor is yours.
Thank you very much. Good afternoon, good evening, everyone. Yes. So I will not have any slides. I will just talk and just look at a few areas which the previous presenters have really covered very well. We are really discussing a very important topic that has potential to redefine health research in Africa. And I must say we are standing at a very pivotal time because being aware of global shifts will influence research for us. I'm going to look at 4 or 5 areas that I am proposing that we should really look at if we really want a paradigm shift. Localized research is the first one, and my predecessors have talked about this. This is looking at research from our context. A lot of times we are at the receiving end. Yes, we write protocols, but then because, as has been mentioned before, funding is external, and the funder is the one that drives the agenda and even drives the outcome and even the use of the research outcomes. But I'm proposing that we really focus on our needs, on our culture, our environment. And we know that even within the continent, we have a variety of needs and cultures and environments. So we should even look at our traditional practices regarding health. Health is not a new thing for us in Africa. We've always been looking at health. We may call it traditional medicine and so on. But we need to harness the local knowledge and expertise that is available. Can we harness this knowledge and expertise to even drive or guide effective treatments that resonate with local communities? And as ASPA, Association of Schools of Public Health in Africa, we cover the continent, 30 countries with a membership in most of the larger areas of the continent. So localized research, how can we drive this? And we as schools of public health can be very instrumental in coming up with research agendas because we are on the ground. We know what the needs are, we know what the issues are, and we can drive the research agenda forward. The second thing I want to mention, which has been mentioned before, is collaboration. As a network, ASFA, we look at fostering networks. We are a network organization. So we need to, and it has been mentioned before, we need to break these silos where we are so defensive because we have our research funds and we want to protect those funds and we want to report to certain donors. We have a need to do our own research. We need to collaborate. We need to, academia needs to come together. And I really want to commend at this stage the comprehensive African health research agenda that is being driven by Africa CDC. In my opinion, we need this critically. We need some kind of direction. And if this comprehensive research agenda can be shared across the continent, it will lead us now to be more collaborative so that the research outcomes are for us and for our needs. The third thing that I want to talk about is local researchers, empowering them. So many times they are co-researchers, they are investigators in the field, they collect data, and sometimes they're mentioned in publications, but at other times they're not even mentioned. So empowering our local researchers to come up with research agendas that meet our need. And for this, we need to provide training, and training does not need to be outside the continent. We have very reputable institutions in the continent, even represented by the speakers that are here. Mentorship, I think, is something that is very critical, not just mentoring PhD students, but even after the PhD period. How can they continue in their research agenda? And something which has been mentioned, funding opportunities. And the predecessor speaker mentioned that we do not even approach some of these funders that are within our environment. We're always looking to external northern funders, and we forget that we have our people, we have our companies that are generating income. Why don't we interest them in funding some of the stuff that we want to do? And this is something that we are looking at as ASFA, and other schools and other institutions for public health can look at and generate funding within the continent. I know we are always looking to outside saying we don't have enough, but I think within us, if we seriously look at what we have, we can drive research that is not that expensive, but which meets our needs. Then the fourth one is has been mentioned before, ethical standards. We are not guinea pigs. We are not flies in a test tube. We have dignity. We need to be treated as people who have a stake in any research that takes place. And we are not going to be fruit flies in a test tube. We need to be at the table. We need to be engaged right from co-creation of research. We don't want to consent to protocols that have been developed without our participation. So I'm for looking at right at the beginning, conceptualization of the research that we want to undertake. And I'm happy that Africa CDC again is leading us to look at priorities that we have, and then later on we'll come up with how to move towards getting research outcomes from these priorities. Then lastly, because things are shifting, technology. Technology, for instance, we are in a digital age, we have technology, and we can even embrace, for instance, data analytics. And we usually don't look at data analytics. We think it's something that is so complicated. But as I spoke, if we are in a co-creation mode, we can start even with community health information. It has been proven that data from the community can inform the health system and can drive policy and can be used to come up with valid findings that drive our own agenda in trying to shift the diseases that we are grappling with. So those 5 areas: localized research, collaboration, empowering researchers, And lastly, ethical standards, which I won't go into. It has been quite addressed well. And of course, technology. So in those areas, if we are going to have a shift in research, I would propose that we look at those areas in addition to other areas. Thank you.
Thank you very much, Professor Kaseje, for your contribution and for making those key points which have been really taken very seriously. When I look at the time, we are at the top of the hour. We've been trying to answer some of the questions in the chat. I just want to assure our participants that this is a first of a series of engagements that we are going to be having within this discussion of paradigm shift. And even if we didn't succeed to answer some of these questions, we would see how we can share with you the frameworks, and then also with the consent of the presenters, we can share the presentations using the link that using your contacts as you register for the webinar. I also want to respect the fact that some people connected very early on, and we don't want to make the webinar to go beyond the time. But as I said earlier, we are ready to continue the engagement. And on this note, I would like to invite Dr. Fala to come in and provide us with the closing remarks. And before then, I would really like to express our sincere gratitude to the different panelists, to the different participants, and to those who were working in the back office to ensure that the link works and also that the webinar could be well organized. Thank you very much, and over to you, Dr. Fala.
Thank you so much, and thanks to our speakers, Margaret, Oluwami, and Tracy, Jackie, and John. This is excellent. Critical things came up. Why are we not having domestic funding in research? I had a conversation with Professor Adiwole, and he said to me, Mosoka, sometimes the university are at fault. The university are interested in publishing and being author. And instead of going to government, realizing from government, what is it that is facing the government today? And how can our university product help to solve the government problem? We know some of the professors from Harvard were able to find treatment, the vaccine for COVID. They became billionaires. Well, for the years that we've run our universities, how many times have we gone to the government and say, from the data we're seeing, this is the problem, how can we solve it? And I know a young man coming to me and saying that, what do we do with all of the dissertation and theses that our graduates are producing? How do we take those one and do implementation research to solve some of the problem? So, and again, academics need to think more inward. We need to think and make some strong decisions. Where I went to school in the US, we had an entire industry owned by the university. It was called a co-stream, so that researchers who have done fundamental research can transition to the industry to manage. So it was a bad direction. Maybe we need to think more, and maybe Africa CDC, that's why we're trying to work on this new ecosystem of bringing together academic institution, what we call in the research R&D ecosystem, the research institutions, the government, public health institutes, and the industry to answer questions. Last week, we were at the ARIC in Ethiopia. And it's very interesting what the director said. He said, you know that we grow sugar, we produce sugar, but the pharmaceutical industry in Ethiopia needs high-grade sugar for the pharma industry. They need starch. We produce starch all the time, but now we are doing R&D to produce the kind of industrial level starches that they need so that we can have this connection. How are we doing that? I think we need to have more of these discussions beyond just speeches and presentation to get our feet daily and very work. And the advocacy we've been doing to government as academics, I think there are two errors we make. One, we bring them at the tail end of our research instead of sitting with them and saying, what are your research priorities? The second thing we do is that we get to government, we tell them how many lives are lost. Politicians are not, it is okay, but politicians most often are not interested in the number of lives saved. They want to know how many dollars they will save if we do a research that reduces malaria burden by 20%, and we'll give them the dollar amount. But again, this is a good start in the paradigm shift. We'll be reaching out to many of you, so our brilliant speakers today. as we try to co-create the R&D blueprint for the continent to reach it. But all of the points you raised are so vital, require so much sacrifices. How we can convince our philanthropy to donate because they will get direct benefit. So thank you so much. This is a great start. Thanks to everyone in the team. We're going to engage with most of you. We'll get your contact as we're trying to co-create the next steps and then how we come together to work hard. We really need to work hard because we have a lot of catching up to do. We really got to commit ourselves to hard work with a lot of passion. Again, thank you so much. We are over 90-some more speakers. This is great. And we'll continue to engage you and say we have to change this. Africa has to change. There's no luxury. We are facing continuing threats. Disease burden continues to increase. And for the purpose of the fact that we are growing more young people, we need to be able to find economic alternative by going to R&D and industry. It's time for sacrifice. It's time for strong vision and resiliency. Thank you very much. Enjoy the rest of your day.
Thank you very much, Dr. Fala, and have a nice day to everyone. Bye-bye.
Thanks, everyone. Bye-bye.
Thank you. Bye.
Bye-bye.
Thank you. Bye.
Bye to everyone.